Thanks, David. And I'd also like to thank Kimberly and Clarion and the members of the forum for giving me the chance to join you today. And as several of us have said, for actually making this thing actually happen here in the last couple of days of July in Washington, D.C., which was a challenge they accepted and actually brought off with much grace and good humor, despite the wanderings of all the planning committee members, including me. So, listening to the conversation this morning, I thought I wanted to start with a couple of things that I hadn't planned on saying to kind of place a little bit of context around my remarks. So my marching orders today were to try to help lay out a little bit more clearly some of the basic concepts around universal health coverage and covering the informal sector, linking finance and delivery, and sort of helping us to think, to have a clearer, better defined conversation. As I listened this morning, I really felt that we were taking up a very complicated topic with a lot of different threads, and that it was not going to be easy to bring those threads together. So I want to start with that. I want to paraphrase the aphorism that's often assigned to Jonathan Swift from Alice in Wonderland, that if you don't know where you're going, any road will get you there. And in a sense, we have a lot to think about, to know where we're going, to know what the roads are that could get us there, because there are multiple roads that could get us there. And as I think you'll see from my presentation, even to have a clear idea of where we're starting from, because we often don't know very well where we're starting from in terms of the issues that we're taking up in this discussion. So what are those issues? I want to just sort of, if you will, sort of throw the pieces on the table first and then see if we can put some order to them. Well, we're talking about universal health coverage. And universal health coverage basically includes two very basic concepts about coverage. One is service coverage, that is the actual utilization of services. And the other is financial protection coverage. And those are sometimes overlapping, but they're actually two different things. And we need to keep that clear. We're talking about occupational health and safety. Well, occupational health and safety encompasses a certain range of health services, which are part of universal health coverage, but also other kinds of needs and services, which may or may not be part of universal health coverage. So that's a kind of a domain that we're trying to bring into this, and we've been talking about benefit packages and so on, but occupational health and safety has certain implications for thinking about benefit packages. We're talking about the informal sector or the informal workforce or informal employment, and that's a descriptor, or as we heard from Martha, really a variety of descriptors of a certain subset of the population. This is a group in the population, and we think about equity as part of universal health coverage, but equity is a concept that has to be defined more precisely. Which groups in the population are to be the focus of an equity emphasis in developing UHC? And to what extent does the informal sector or the informal workforce fit into that concept? That's a third dimension of the problem we're dealing with. And then a fourth dimension is much of the conversation about universal health coverage has really been about state action, has been about the government and what the government should do to lead and develop national efforts to achieve universal health coverage. But then, as we heard this morning, this is a forum about public-private partnerships, and there's a certain impatience. It's not necessarily the case that we only want to talk about medium or longer-term state actions to advance towards universal health coverage, but an urgency, as Derek pointed out very much at the beginning of this conversation. What can we do today with innovation and with public-private partnerships? So bringing those 5 elements together in a single conversation is very challenging, okay? And I would urge us to try at least to keep track of which part of that conversation we're having at a specific time and place so that we don't be talking past each other or at cross purposes, because I really think there's a risk. Now, it's an exciting conversation because there are different points of view and different experiences coming together. And I have to say personally, that's one thing that really attracted me to be part of this conversation is, I think, well, I've been working on universal health coverage with ministries of health, but I haven't heard people representing the informal workforce talk about their experience with this, and I believe that that's very important. So I wanted to learn about that. But at the same time, I have to pay attention to who's speaking from what perspective about what subject, and I want to urge us to do that. So with that as an utterly confusing introduction to my remarks, I want to give us some things to think about in terms of universal health coverage and the informal sector. So first I want to come back to definitions, and I kind of like to do that. I guess I'm a kind of a person who likes to try to be precise about things. And I think we should pay attention to the shifting concepts and definitions that have been taking place as universal health coverage has entered into the global political discourse. And it certainly is in the global political discourse, especially now with the discussions about the Sustainable Development Goals. So the initial discussions about universal health coverage were what I would call very broad and aspirational. In the World Health Assembly in 2005, paraphrasing a bit, universal health coverage was defined as would be achieved by a health system that would guarantee access to all necessary services to everyone while providing protection against financial risk. So this is a very broad aspirational goal. All needed services to everyone. We should acknowledge no health system in the world achieves this goal, okay, today. No health system provides all needed services to everyone. But it is a noble goal, and we should all be working hard to try to achieve it. Even if we accept some limitations on what is necessary and what we mean by financial risk, this kind of a health system would produce the highest attainable outcomes that a health system can achieve. It would be the top performing health system, and in both health output, health status, as well as financial protection. And since I think there are 3 broad goals of health systems, health, financial protection, and the satisfaction of the citizens in the country, I would assume that if we gave the highest level of health and a high level of financial protection, probably we'd have pretty satisfied citizens. And if we reached all people with this, that would be a great thing. As that definition has entered into the global discourse, it has been rolled back a bit. In planning this meeting, we used the UN General Assembly resolution, which you see here on the screen, and I've highlighted in red some of the terms that I think are areas we should be paying attention to as we think about definitions. So the term access. Access has a lot of different meanings to people. It could mean physical and social access, in other words, that things are available to people, or it could mean the actual realized utilization of services. Not just that they're available, but people have realized that access, and those who need services actually use them. So this definition doesn't actually say that, but it does use that term access, which could be interpreted in different ways by different people. Then it talks about basic health services. So the original definition talked about all necessary health services. This one now talks about basic health services. Well, what does that mean? What are basic health services? If I need an expensive procedure to save my life, you might think it's basic, but I might not. Or I might think anything that I need to save my life is basic, and you might not. So we see a little bit of a kind of a wiggle room there as in this definition. And we see words like essential being introduced. And then when it comes to financial protection, we see the term, it does not expose the users to financial hardship. Well, I don't know if that means they don't encounter financial hardship or somehow they're not, I don't know exactly what it means. So my point is, we're starting to see a reduction from this ambitious and aspirational goal to something more practical as it starts to enter into the global discourse. I'm not saying that's a bad thing, but I think we should be aware of it because it does open the door to lots of questions. For example, are the services we would consider part of occupational health and safety basic health services, right? So, or could a country achieve universal health coverage by this definition and not be delivering the services we consider, some would consider important for occupational health and safety? I don't know the answer to that question. Let's turn to another recent effort to define measures to monitor progress towards universal health coverage. WHO and the World Bank recently produced a guidance for indicators of universal health coverage, which is based on a subset of health services and some summary financial protection measures, and also breakdowns according to income quintiles. Now, it is proposed that this is the way that countries will monitor their progress, and presumably if they do better in some sense on these indicators, they're doing better in terms of achieving universal health coverage. But what are these indicators? Well, this is one of the charts from that guidance. I didn't present them all because there are a number of them. And you can see 4 countries arrayed on this chart: Chile, Egypt, Tanzania, and Bangladesh. And you can see at the bottom these little icons which indicate different kinds of indicators: measles vaccination, non-use of tobacco, TB case detection, hypertension treatment, diabetes treatment. And you can see what I think we will see if we use this kind of measures all over the world. Countries do better on some and not so well on others. So how do we use this kind of information to say one country is doing better than others in universal health coverage? Well, there are some answers to that question. We do have in this kind of indicator measurement world something we call dominance, which is that a country is doing better on all indicators than another country. So we would say that country is doing better on universal health coverage. But for the most part, we're not going to see much of that dominance. What we're going to see is a mix of high and low levels of these indicators and improvements, hopefully, over time, but some will improve more than others. Some might not improve, some might go down, and some might go up. And is this what we're talking about when we're talking about universal health coverage? Where's occupational health and safety in these indicators? And what we see in the measures are breakdowns by income quintiles. Where's the informal sector? Is the informal sector all the lower income quintile? So this simplification proceeds, and we seek something more measurable and more usable. So I'd like to just pose a couple of questions that we should keep in mind. I'm not trying to give answers to these questions. I think these are important questions as we encounter the topic of this workshop. So does access mean utilization or actual receipt of services, or just availability? How do we think about entitlements? If people are given a legal entitlement to receive a service, is that coverage? Well, in financing, in the world of health insurance and financing, it is. When an insurance company says you have coverage, it means you have a contract that entitles you to something. They may or may not be terribly involved in whether that contract is actualized or enforceable, and in many countries we see that it's not. So there are obligations that are given but are not actually realized. In service delivery, coverage precisely means that those who need services receive them. So coverage means actual utilization, and if we use the term effective coverage, it means receive them at a level of quality sufficient to achieve an outcome. So we have different definitions here underlying the health and the financial protection aspects of universal health coverage. And of course, as you can see, when you start to unpack this stuff, you really are going to end up with questions about what does it mean in terms of progress at a country level? What does it mean if a country makes progress with coverage, actual utilization of some services and not others? What does it mean if it makes progress with coverage of some population groups, but not others, or some groups are lacking? And what does it mean when different degrees of financial protection are achieved? So that brings us to the UHC cube, which Bob warned us we were going to see several times today. That's because he probably had seen my slides, so he had advance warning. So look at this cube. It talks about 3 dimensions. On the horizontal, the population who is covered. On the 3rd dimension there, going into the depth, the services, which services are being covered. And on the vertical, the height, the degree to which financial protection is achieved, that is, how much out-of-pocket spending are people bearing to cover these services. What does the point represent in the upper corner there? It represents a health system that achieves 100% of all 3 of those dimensions. That's that great aspirational goal. But something that's very misleading about this cube is that it sort of is filled, in this particular version, with a smaller cube which represents the current health system performance. But that's not actually the way current health systems look to the populations. They kind of look more like this, okay? They look like different groups in the population have very different mixes of who is covered for what and at what degree of financial protection. And that I would add one more dimension to this question, which is who is covered for what, at what degree of financial protection, and by what part of the healthcare system. Because people are segmented in healthcare systems according to different arrangements of finance and delivery. Okay? And this is a very critical part of the conversation about universal health coverage. This is the part where I was mentioning that we not only need to know where we're going and the roads to get us there, but where we are today. Because we often don't have a very good picture of where we are today for the different groups in the population in terms of how they face the challenges of accessing healthcare and financial risk protection. Think for a minute about the informal sector. So are they mainly located here in the bottom 50%? Many are. Some might not be. Okay, so how do we think about that? We saw earlier today a chart which talked about the financing mechanisms for the formal sector and the informal sector. But that chart listed on the informal sector user fees, other kinds of financing mechanisms. But one very important financing mechanism was not emphasized, and that is the government, and often the external partners of the government, are financing the public delivery system. And that highly subsidized or often free system at the point of delivery may be the existing finance and delivery model for that bottom 50%. So should we be changing that model, adding health insurance to that model, or should we be trying to make that model work better? That's basically a more practical question. It's a question about the instrumentalities of improving or advancing towards universal health coverage. And so I think this kind of segmented picture leads us to thinking about some of the practical questions that David wanted us to start focusing on, which have to do with what's existing today and what can be done to improve and build upon what's existing today. In some cases, it might be intervening to improve the functioning of the public delivery system. In other cases, it might be creating an insurance or other financing mechanism to provide an alternative or a complement to the public delivery system. What we see in many countries today is a rather confusing mix of these kinds of strategies. Okay? We see, for example, in India that the government has financed health insurance for the poor, which largely pays for private hospital services. At the same time, the same government is allocating budget to build and improve public hospital systems, which are supposed to provide free hospitalization for the poor. So what's going on there? What's the nature of that strategy? And what can we learn, and how should we think about those questions as we think about universal coverage for occupational health and safety and the informal sector? So that leads me to say that some clearer thinking about these questions, I think, is essential to make progress. And we need to understand for each country, and each country is going to be different, It's going to be different in terms of the institutional structures, and it's going to be different in terms of the population groups. What kind of coverage, both service coverage and financial protection coverage, is currently available to whom, with a particular focus on the informal sector? For example, the government provides in many countries often a constitutionally based entitlement of comprehensive free services. What actually exists? What should we do about that? What should we do about what actually exists? Employers or social health insurance may provide an entitlement of financial coverage, but what is actually provided? The experience in many countries is that social health insurance is given to people, but they continue to go and pay out of pocket for private services. That entitlement is not realized in whole or in part in many countries. And then if we can understand what's going on, what strategies should we undertake to assure that missing coverage or expanding the coverage to priority populations? Should we strengthen government finance and delivery, or should insurance coverage be expanded, and so forth? And that, I think, gets us into lots of very hard, practical questions, questions around learning what's on those pathways to get to universal coverage, and which pathway should we be following. So we need better evidence for those things. We need to know the current situation and the gaps. We need to have an honest assessment of the potential for remedies to fill those gaps. If you ask people in the Ministry of Health what is their biggest problem in achieving the coverage they already promised to people but they don't deliver, it is give us more money. That's their... if you ask other people, they might say, please don't do that. It's just a waste of money. What's the truth? We need to have a way to kind of come up with an honest assessment. Can we strengthen government delivery? And if so, how? Is there sufficient service supply or administrative capacity to deliver services or to implement alternative methods? We need to learn from others. And we need to acknowledge that the answers to these questions are not going to be the same in different countries or even in different parts of countries. I strongly believe that we are not in a one-size-fits-all world. We are in a world in which local institutional conditions matter a great deal for the choices that need to be made. In teaching about health systems and reform, the phrase imitate but adapt comes up quite often. You certainly have to learn from what others have done, but you should not adopt whole what others have done, but adapt what they've done to your local situation. And this notion of conditional guidance, we can learn from others, but understand the conditionality of that learning. And finally, I want to say something about some of the big risks that we face in this conversation, because I do feel that while the movement to universal health coverage is extremely exciting, it also has some very serious risks that pose dangers for us. The first of these, I think, is the risk of unfunded entitlements. The UHC movement has a serious risk of tempting politicians to promise benefit entitlements and launch underfunded schemes to deliver them. And that's a great danger to everything we're all trying to accomplish. We need to be rigorous about what we can actually afford to pay for. As we heard earlier, India today, the government probably spends about $20 per capita on all health services. That's the All India Institute of Medical Sciences, the top tertiary hospital in the country, all the way down to the community health workers in Bihar and Uttar Pradesh. Mexico and Thailand, models that we've talked about quite often for universal health coverage, spend levels of financing that are 5 to 10 times higher than that per capita. That's a big difference, okay? So we really do need to pay attention to this question of what can be financed, and that may require some hard choices, especially if we want to emphasize the needs of the informal sector and certain kinds of other health needs. The second big risk, I think, has to do with duplicative schemes that are going to compete for scarce funding or scarce delivery inputs and undermine all efforts to go forward. I gave you the example of India's new government insurance scheme, the RSBY, which essentially finances hospital services in private hospitals, not everywhere, but more or less, while the government continues to finance public hospitals and also competes with government funding for primary care. So how to balance these things? And the same is true for human resources. If more money flows into hospital services, human resources will be attracted out of primary care. And the time period that's required to build up human resource capacities is much longer than the time period that's required to launch new schemes and put money into new areas of the health system. And the final question, the final risk, I think, is this question of multiple tiers of coverage entitlement. As we've seen, civil servants, formal sector workers, they often are able to get high levels of coverage through early schemes that were put in place. And today, what we're finding around the world is that this kind of multiple tiered health insurance coverage or financing coverage system is very hard to undo or to create a single unified model of insurance coverage. Even countries which have been very successful at advancing towards universal health coverage, naming again Mexico and Thailand, have been incapable so far of undoing that multiple tiered system. And it's only at much higher levels of income, a country like Taiwan in recent history has been successful at doing that. But that's at a level of spending that's, again, perhaps 5 to 10 times higher than Mexico and Thailand. So having much more money in the system. So it may be that this multi-tiered system is a problem. It may be that it is something we need to accept on the road to universal health coverage. And what we should be focusing on more is how to prevent the resources to address the needs of the poor from being siphoned off into somehow supporting those other systems. So I haven't said anything about the public-private partnership side of this, but I just would add that we do need to think about these big system design picture questions, but we also need to think about the practical process of doing something today on the ground to meet the incredibly difficult needs that Martha shared with us and earlier. And there is, I think, a great scope for innovation and action, which is not going to solve every problem or not deal with every problem at scale, but could help us devise solutions. And that's where research and learning and strengthening the overall knowledge base, I think, will come into play. Thank you.
Thank you, Peter.